Medicine has become so complicated, up to the point that now you've got one patient and a lot of specialists. First of all, you've got a family doctor, but of course you've got ophthalmologists, and there's something on my leg, let's have a look and see, so you need a dermatologist for that. And there's something that doesn't look nice, let's send a biopsy, so you're going to need a pathologist for that. And let's see if there's anything else in the rest of the body, so let's call the radiologist, but then, oh, it looks bad, let's take it out. You need the oncologist. Is it the clinical oncologist? Is it the surgical oncologist? Is it the radiation oncologist? And then, oh, the bloods don't look right, so let's ask an opinion from the hematologist as well. So you see that we went from a situation when we had one patient and several patients and one doctor to one patient for a lot of doctors, and often for a very similar problem. The problem here is that if doctors don't talk to each other, so you've got a disease, but then what's going on? And you need to put all the pieces together. So how does this apply to our conversation today? So I'm going to show you three scenarios. The first scenario is very common for ophthalmologists. So eye check, routine eye check, or there's something going wrong with vision. You pick up something that doesn't look nice, so you investigate the patient and you find a cancer diagnosis. So you will need to involve the oncologist. This will be the theme of the warm-up of the meeting with these, in Italian we would say tridente d'attacco, given that the Mundial is just going to start in a few days. Rapid fire with cases from the UK and from Switzerland of tumors that actually started within the eye. Now, if you look at another situation, so you have a patient who's got an ocular or periocular tumor, but in this case, they need radiation treatment. After radiation treatment, they develop complications in the eye. So you're going to need an ophthalmologist, and especially an ocular oncologist, to look for that. Now, this is going to be the object of section 1, where we're going to have an idea of what happens with radiotherapy around the eye and inside the eye, especially at the level of the retina. Now, there's a third scenario here. So we've got a patient who's got a known extraocular tumor who receives treatment for that, be it immunotherapy, target therapy, anything. And this patient develops ocular side effects. So in this case, what you need to do is you need to check, is this a good side effect or is it a bad side effect? So section 2 will focus on the bad side effects of some of these medications, and of course cutaneous melanoma is a little bit of the protagonist here. Section number 2 will actually look at the unexpectedly nice side effects from treatment of tumors on the eye. Hopefully, by the end of the meeting, it will be a little bit more clear to all of you how specialists need to talk with each other when these problems arise. And that's why I will welcome you officially and fasten your seatbelts. I hope you enjoy the meeting. Thank you.
So, I would like to start my presentation with the 3 key points. First one, I think that you already know, that is the PAC Center. PAC Center is the practice where Dr. Simona with Dr. Faila work. And it's really a factory of so many interesting clinical cases, such as the one that I will present to you now. It is really a place for great discussion and insight about so many ophthalmological topics. Second key point is the class of natural molecules derived from seaweed that is actually used for the treatment of many tumors. We will see later. Third key point, I will not ask you to say what is here. That is, we will talk about a case of a small cell lung carcinoma. That is the histology photos. So let's go to our clinical case. It's a case of a 70-year-old Swiss man that is also known for hypertension. He is a smoker, our patient. Also with a history of hepatitis C and tuberculosis. And not last, he's undergoing chemotherapy for a small cell lung cancer with lurbinectidine. We will see later what is this in phase 2 clinical trial. Let's go to have a look clearly to the history of our patient to better understand what's going on with this patient. So in 1952, our patient was born in Switzerland. In February 2017 was made the diagnosis of small cell lung carcinoma. In November 2017, our patient developed in the right eye a central retinal vein occlusion with macular edema. And he underwent extern, so this is an amnestic history. Until this moment, we didn't know anything about the patient. We didn't see yet the patient. He underwent 3 intravitreal injections with Lucentis. And in July 2018, the patient came to PAC Center for a second opinion, for ask for what's going on with this recurrent macular edema in his right eye. So let's go to our visit. The visual acuity in the right eye was 70%, so not so bad. Left eye 100%. Eye pressure and anterior segment, both eyes are remarkable. We made a multimodal imaging. Let's see the fundoscopic image of the right eye. We can see here certain vascular tortuosity, some dot hemorrhages in middle periphery, and probably still macular edema. When we take a look on the left eye, nothing important, relevant for our discussion. So we performed OCT in the right eye, and we can see the presence of macular edema. So we confirmed the treatment with intravitreal injection. So we planned and performed the 4th intravitreal injection with Lucentis. So on the follow-up scheduled date in August, following the injection, this was the situation, the ophthalmological scenario in July, the last one. And after the injection, we can see that the macula is totally dry. So we were very happy. But we knew that this patient was undergoing a chemotherapy. So we would like to inform also the oncologist what's going on with the eye. And we called them, our oncologist colleague, but our oncologist colleague were not so happy. While they told us that was better to stop with intravitreal injection, while they thought about potential confusion in case of development of ocular adverse reaction under the treatment with ranibizumab. So they suggest to stop. So we planned another control of our patient. This was the situation that we saw last time in August. We saw the patient once again in October, and we can see once again macular edema. We can't do substantially nothing, so we limited to observe and plan another control. So this was the situation in October. This is the situation in November. And with great surprise, we saw a regression of macular edema without intravitreal therapy. We can see here only a small foveal cyst, but a great macular edema regression. So what you would do now? What would you think about what's going on? So we took a look on the systemical anamnesis of the patient. We saw that was under chemotherapy. So we thought call again our oncologist colleagues, and they told us that this patient made a chemotherapy session on 16 October. Okay, interesting. We noted on the patient clinical file, and we plan another control to see what happens. So this was the situation in November. We saw the patient in December. Once again, macular edema. So we limited to observe. We can't do any intravitreal therapy. This was the situation in December. We saw again the patient on the 8th January. So an increase of macular edema. But the patient had no made under a chemotherapy session. So we asked to our colleague oncologist when was planned the next chemotherapy session, and we organized a control after the chemotherapy session. And you can see here that on 22 January, after a chemotherapy session, it's made 4 days ago, the macula is totally dry. So, when we take a look on the overall images that we made until now, we can clearly see, I think that you totally agree, a progressive and regressive trend of macular edema depending on chemotherapy session followed by the patients. What's going on? When we take a look on OCT progression analysis, you can see in red lines the chemotherapy session made by the patient with the lurbinectedin, and in green and yellow line the macular thickness. And you can note the decrease of macular edema following each chemotherapy session. And you can see here the zoom. So I think that you already know about the Professor Rosenfeld Caswell discovery, but what we are looking until now, what is this? We made an insight about this new molecule that we naturally didn't know. What is this lurbinectedin? Just few words, and then I will leave the discussion to Dr. De Salvo. This lurbinectedin is a natural marine molecule isolated from a Caribbean seaweed that is actually approved for the treatment of advanced soft tissue sarcoma, and it's currently investigated in phase 2 clinical trials for treatment of small cell lung carcinoma, breast, ovarian, and uterine cancers. Many studies were published about this topic. Lurbinectedin belongs not to a new class of molecules. We already know alkaloids from vincristine that is known for its effect on retinoblastoma. So, which are the take-home points with this clinical case? First one, you have seen here the first report about the possible benefits of lurbinectedin in a case of a central retinal vein occlusion associated with the macular edema. Second one, you have seen here this class of alkaloids, and then Dr. De Salvo will talk later about. That could be interesting substance for many also ophthalmological disease. It's possible that they can protect from oxidative stress and reduce VEGF activity. Third, the bioactivity of lurbinectedin must be undertaken to understand if it's possible to use locally and to avoid unwanted adverse events. This is my bibliography. Not last, I'm happy to announce that this clinical case a few weeks ago was accepted and published on American Journal of Ophthalmology case report. Thanks also to the collaboration with San Raffaele Hospital of Milan, Professor Queques, Dottoressa De Salvo, and Thank you.
Thank you very much for the kind invitation to Dr. Simona and to the PAC Center, and obviously to Gabriella. My name is Dr. Gabriella De Salvo. I'm a consultant ophthalmologist and I work at the University Hospital in Southampton, UK, and my expertise is in medical retina imaging. So thank you so much. I was asked to make a little bit of points about and run a discussion about the case that Feliciana just showed us, since as you can see, after seeing all these possible disasters that the chemotherapeutic drugs can give to the body and to the eye, hopefully we have some hope in the future. These are my financial disclosures. And since we are a multidisciplinary audience, you will forgive me if I'm getting a little step back and discuss a little bit what it is about this condition that this patient had. So this patient had the retinal vein occlusion, which is an obstruction of the retinal venous system caused by a thrombus, and the thrombus is mainly formed by the compression of an atherosclerotic vessel. And the vein occlusion can actually affect the entire retinal central retinal vein, so including the 4 quadrants like in our patients, or it can affect the hemiretina, either superior or inferior, or it can affect simply a branch. Okay, this is the left eye in this case. And obviously, what do we do when we see these cases, and how this is happening? This is happening because the atherosclerotic vein is compressing the atherosclerotic artery is compressing the vein, and therefore this is causing an increase in retinal capillary pressure, and obviously this is increasing the permeability but also the leakage, and therefore this is then causing a possible ischemia and obviously macular edema. And as we saw from the presentation that Anne from Lausanne presented us a few minutes ago, we can also end up by losing the eye with a very dangerous neovascular glaucoma. So how do we treat this condition? For those of you who are not ophthalmologists, we're now treating this condition by injecting directly inside the vitreous a substance, which could be either an anti-inflammatory implant, we call it Ozurdex, or we can inject the anti-VEGF injections. Some centers are giving this injection on a basis of a treat and extend, meaning once the vision or the back of the eye stabilizes, we still keep injecting, but we extend the interval between the injections, or we can also inject when needed in a so-called PRN regime. And for those of you who are not used, and you've seen a lot of these pictures, but you're not ophthalmologists, we tend to follow up this patient, and we study the response to the treatment and make a diagnosis thanks to this instrument, which is called OCT, optical coherence tomography. This instrument is very popular, and all our patients nowadays are having this scan made on a daily basis, and we do a lot. We have even virtual clinics where these patients are coming and having just scans. In my hospital, we do 1,000 images only for virtual in a month, only virtual imaging, and we do 100 anti-VEGF injections per day. So very, very busy business. So what it is, basically this instrument is very common, as I said, and it reproduces you like an in vivo image, and it's very well tolerated by kids, and we love it because it's a didactic instrument and it's a valid alternative to invasive procedures such as fluorescein angiogram and indocyanine green angiography. And how does it work? So this is the back of the eye, your retina and choroid, and this is the vitreous. So here you will have your cornea. So the ray of light, which is a coherent light, similar to the light that you're using for laser, meaning that all the radiations are working and are like having the same wavelength, is coming into this direction, is impacting the retina and the choroid, and then is reflecting back, exactly like a normal ultrasound would do. The difference of the nature of the retina and choroid, or whatever structure the ray of light encounters, comes back giving you a different wavelength, and therefore you're producing an image which is called OCT. And therefore, this is the image of the retina that it produces. And this is the official nomenclature for all of us who are ophthalmologists. When we're discussing a retina case, we need to refer to this nomenclature. So to make a long story short, if you're looking at my hand, and this is the back of your eye and the retina, and if you want to see whether this hand is swollen or not, then you're looking at the cross-section. This is what we're looking at, is a cross-section of the retina. So let's go now back, now that I gave you a little bit of information on how ophthalmology works, and particularly medical retina, let's have a look at the case. This patient of the PAC Center was having a lot of a lot of effect, a lot of cardiovascular risks. He had monoclonal gammopathy, he had an aneurysm, he had blood pressure. So there is a possibility that in his case, the central retinal vein occlusion was actually caused by one of the risk factors. But nevertheless, the patient also had small cells lung cancer, carcinoma. So therefore, there is also a possibility that in this particular case, his central retinal vein occlusion was also due to a paraneoplastic condition. And as we heard from Feliciana, the patient, before being referred at PACS, he underwent 3 monthly injections of ranibizumab, which were very successful. And we already saw this. This is an OCT of the right eye of our patient. This is the cross-section, so the macula scan. And all this black area, this is where the fluid was building up. When he came to PACS, the first thing that they did was injecting another of these anti-VEGF injections. So they pick up the same kind of injection that he already had, the ranibizumab, and you can see how the retina that was swollen decreased and went back to normal. This is a foveal pit. This is normal. And therefore, this is what happened, and this is our normal daily life in ophthalmology. And we already saw the trend, because when the patient started the lurbinectedin, we saw this going up and down, this wavy appearance of the OCT based on the possible effect from the lurbinectedin. At that point, as Feliciana said, the oncologists refrain from treatment of anti-VEGF inside this eye, because obviously they didn't want to get confused, because before the lurbinectedin was experimental back then, so basically they weren't sure whether eventually the fluid or infection or whatever could have been a side effect from this new chemotherapeutic drug. Therefore, this effect must have been certainly related to the intravenous injections of this new chemotherapeutic drug. So to go back to the question is, as lurbinectedin having an anti-inflammatory effect, or is this possible a new anti-VEGF? We don't really know. What we know, and as you already saw, is that in a very recent phase 2 clinical trial, this has been shown that these patients showed a median overall survival of 9.3 months, which I understand, being this cancer very, very dangerous for life and having a high rate of mortality, this was very important. Therefore, this data brought to the approval in 2020 of the lurbinectedin being accepted by the Food and Drug Administration as a second line for the treatment of patients with small cell lung carcinoma. We already heard that from Feliciana, the lurbinectedin, even though is commonly used now in some subcohort of patients, is still a chemotherapeutic. So obviously it can have also some collateral effect, and particularly these patients can be affected by anemia, leukopenia, neutropenia, and thrombocytopenia. So not nice, obviously. But nevertheless, at the moment, it's still again under investigation or under check with another clinical trial, which in combination with other cytotoxicity drugs is trying to understand which other patient can eventually be beneficial by this treatment. So I learned, thank you to this lesson, that we have multiple types of chemotherapeutic drugs. We heard that lurbinectedin is a part of the plant's alkaloids, but there are, as we heard today, many types of chemotherapy which can instead give a lot of side effects to the back of the eye. And I was involved with the publication of this patient and of this particular case, where we are just suggesting a new possible beneficial anti-edematous effect of this drug in patients who've been affected by central retinal vein occlusions. But obviously this is just one case, so it could also be coincidental. But what is angiogenesis, and why are we all here together in this room? So what is that is the common denominator between the oncologist and the ophthalmologist? I would say that the common denominator is without any doubt the angiogenesis. So what is angiogenesis? Angiogenesis is the process of formation of new blood vessels. And this is a multi-step process. This is not something that happens from today to tomorrow. And there is also a balance between positive factors and negative factors, and when we reach an imbalance we will go towards the angiogenesis, and it happens slowly. We have a degradation of the basal membrane, we have the migration of the endothelial cells, and then we have a proliferation of the endothelial cells. And obviously the first movements for this angiogenesis process is obviously the hypoxia, so lack of oxygen, but also the production of VEGF, of the vascular endothelial growth factor, that when goes crazy can obviously interact even more with the two receptors attached to the endothelium, so the receptors 1 and the receptors 2, particularly the receptors 2, and therefore favorite the proliferation and the migration of these endothelial cells. But why we don't like it in oncology, this angiogenesis? That's simple. We hate it because when first of all, we're feeding the tumor with new blood vessels, and therefore the tumor becomes more resistant to possible drugs, or whatever type of drugs you decided to use. The tumor will be more resistant, more robust, and also it will increase the chance of traveling away, because we're building new highways for the tumor to spread. So the VEGF seems to be a disaster for the body, but actually it's not, because in effect we need the normal level of VEGF, and we need it because they're important in the endothelial cell survival, but also they affect the neuroprotection. When we have a cat, or we have a menstruation, this is also a very important factor to have the VEGF there present to help our body to heal. So why then are we fighting it? We're fighting it for the reason that I just said. So we're fighting it with anti-VEGF molecules, and both of us, both oncologists and ophthalmologists, are using them day and night. The most common of these molecules is bevacizumab. Bevacizumab, also called Avastin, we saw it in many other slides previously. It's a recombinant human monoclonal antibody against VEGF. To make a long story short, is your classic IgG. It's an IgG. And what does it do? It blocks your VEGF-A, and therefore the VEGF-A cannot anymore interact with the photoreceptors, and therefore it blocks the downstream pathway, therefore blocking the proliferation, the survival, the vasodilation, and the migration of the cells. The good news is that in oncology, Avastin is used to treat alone, or possibly you will know better than me obviously, but in combination with other chemotherapeutic drugs, a lot of cancers, especially the advanced small cell lung carcinoma, but also the carcinoma of the colon, the rectum, the cervix, the ovarium. It seems like the panacea for the treatment of carcinomas, while in the eye is actually by surprise used as an off-label molecule. So yes, we as ophthalmologists are using Avastin right, left, and center, but we're using it as an off-label drug. So it's not a drug approved as an anti-VEGF to treat ocular conditions. So keep it in mind when you're treating your patients. These are instead the drugs that we are like more covered, more comfortable to use, and they are, with one of them you're very familiar, aflibercept, but the others are like, this is the oldest one, and then brolucizumab and faricimab are the newest, I would say. So, the ranibizumab, you probably heard, for those of you who are not ophthalmologists, it was a very nice idea to get it from the Avastin. This is the Avastin on the right, and they took a portion of the Avastin and they created the Fab fragment and they called it ranibizumab. They thought that the smaller molecule had more penetration. Therefore, it was a brilliant idea, and this was used as forever, and is still used, and obviously is approved for any possible chorioretinal vascular disease that we can treat. But this came out of surprise to me, because even though we're very used to use aflibercept in ophthalmology, because it comes with a prefilled syringe, is very well known as VEGF trap, because these two arms are like composes the receptors that you find on the endothelium, that they're trapping the VEGF, and then you have your FC fragment. But what I wasn't sure and what I didn't know was that it was also approved for the treatment of metastatic colorectal cancer. So that to me came actually as a surprise. And obviously this is also fighting not only the VEGF but also the placental growth factor. So for us it's actually a stronger molecule, because it's fighting two regulator of the VEGF for the angiogenesis. This is one of the newest molecules that we have adopted last year. It's called brolucizumab. But even though it's coming in a pre-filled syringe, and even though the clinical trial has been very successful, unfortunately, the data coming once the drug came into the market, the post-marketing analysis has showed that there are raised a safety alert, because when we inject this drug, there is possibility of having vascular occlusion and vascular events between 2 and 4%. So this is too high to be accepted if you consider that the other drugs have got much less side effects. But this is the newest, the promise, I would say, for all of us in ophthalmology, because it's a new biospecific cross-map antibody. For the first time, it's the same molecule attacking two different molecules, like the VEGF on one arm and the angiotensin 2 on the other arm. And this has been only recently approved for the treatment of neovascular age-related macular degeneration, but also diabetic maculopathy. It seems like fantastic that once before we couldn't treat the eye disease in any way, the retina challenge was there and these patients were getting blind. Now we have these amazing injections that we can inject the patients. But unfortunately, there are some disadvantages. First of all, the frequency. Imagine you have a patient who's already 80 years old and you're going to tell them that they're going to come to your clinics once a month for the rest of their life, in the worst case. So this is challenging for them, for their life, for their family. And therefore, the frequency of the interval of the injections is not easy to cope with. It's a burden for the patient, a burden for the health system. There are costs involved with this, obviously, treatment, and also, as every possibly trial, the outcome of the visual acuity is not as good as when you're doing a clinical trial in protected environment. So these are the common side effects of anti-VEGF injections. This is what can happen with any treatment, but what we fear the most is an endophthalmitis, which can blind the patient within 48 hours. To help us with the burden and the costs of the anti-VEGF, we now have in ophthalmology learned about this biosimilar that for you as an oncologist we are very much aware of. For us it's all new, and they came into the market just last month, so we're learning to use it in Europe, and they're molecules that are highly similar to the FDA drug approved, but remember they're not the same and we're lacking safety information. Why do we have biosimilar? We decided to have biosimilar just to save with the cost, because there is a saving of cost which is approximately of 30% compared to the rest of the other anti-VEGF. But what comes, hopefully, into our future as ophthalmologists is actually the gene therapy. This is what we're hoping for, because actually the eye is the only part of the body that is very well compartmentalized, and therefore also with the help of the ocular retinal barrier, there is the possibility of this drug to go around and be absorbed in the circulation is very low. So this is minimizing the systemic immunogenic response. And if we were able to treat all these patients with gene therapy, we could build a biofactory where the patient itself, with one only injection, will be able to produce all the anti-VEGF needed for the rest of their life. There is only one drug that has been already approved for this scope, and it's called Luxturna, but this is for inherited disease. So to conclude these long excursus, the angiogenesis is the primum movens in both oncology and chorioretinal disease. Anti-VEGF are commonly used to control and to fight this out-of-control angiogenesis process. In ophthalmology, there is an unmet need of long-acting molecule, and we're hoping that the genetic treatment might help us in the long run, and one injection will be forever, but there will be cost obviously involved with this if this is proceeding. And last but not least, because we already have adopted two of the anti-VEGF they've been using in oncology, like Avastin and Eylea, we might hope that maybe in the future even lurbinectedin can have this role, both systemically or even better, injected intravitreally. So obviously this is just a supposition, and we need further study to prove that. But I would like to thank you once again for this kind invitation and for being so patient to allow me to close the meeting today.
Thank you very much for the kind invitation. I'm a medical oncologist at the Istituto Oncologico della Svizzera Italiana, and my main focus is the lung cancer. Actually, I'm not a specialist in melanoma. Grazie. So, we know that severe ocular adverse events are rare, but there is an increasing use of immune checkpoint inhibitors and targeted drugs in the clinical practice of the oncologist. And there are many indications, including in adjuvant setting. There is an increasing use of combination as seen before. And in addition, there are also low-grade adverse events from standard chemotherapy. So in the near future, more patients will be exposed for a longer time. Should we expect to see ocular adverse events more frequently? So the second issue is how can we improve awareness of ocular side effects? I think that these side effects are underdiagnosed in the oncology. So elderly patients may not report vision decline, and the question is, do we routinely ask our patients about vision issues? I personally don't. I don't know if you do it, but I don't not routinely. Is the oncologist aware of possible ocular toxicities? I'm aware about the MEC-R, the immune-related uveitis, but there are many new drugs and are rare adverse events for us. And how often do we refer patients with eye problems to the ophthalmologist for all cases, or only in cases with serious adverse events? So to move on to the positive ocular side effects, anti-angiogenics have multiple indications, as we have seen in ophthalmology, but also in oncology. Dr. Mena presented a very interesting case about the positive effect of lurbinectedin of macular edema. And I think it's the main challenge in the future to find a common mechanism targets in very different diseases. So the importance of reporting the cases and also of the interdisciplinary collaboration. So to conclude, can the eye-related side effects be prevented with screening and monitoring? How? how can improve the early detection of the side effects. This is the important question. Is an ophthalmology consultation before the treatment start recommended for which drugs? Just for MEK inhibitors such as binimetinib, or also for immune therapy? And also, what is the role of a nurse assessment in the oncology? Could be helpful, maybe. How to promote the patient education, the oncology patient education is also an issue. Thank you very much.